Hello, everybody. Welcome to Pediatric Grand Rounds. I'm going to turn it over to our Vice Chair for Education, Dr. Sandrain Van Schaik, to introduce our speaker for today.
Hi, good afternoon, everybody. Welcome to Pediatric Grand Rounds. This is the third in the April series focused on equity. For those of you who haven't noticed this, but a couple of years ago, we actually created some thematic areas in Grand Rounds, and equity is one big topic that we address on a regular basis, and all the sessions in April have an equity focus, which doesn't mean that after April we're done. This is continues to be a very important area that we want to continue to highlight. So if anyone has good ideas for speakers, you can always contact me or Charisse, and we will try get people scheduled. But for today, I'm really pleased to welcome Dr. Lena Weinstone. Dr. Weinstone earned her medical degree at Stanford University School of Medicine and then did her residency at Lucille Packard Children's Hospital, Stanford, and her fellowship in pediatric hematology and oncology at the Children's Hospital of Philadelphia. She also has a master's degree in health policy research from the University of Pennsylvania Perelman School of Medicine, and we're incredibly pleased when she got recruited to UCSF to be here on faculty in 2018. Her research explores racial, ethnic, and socioeconomic disparities in children's access to cancer treatment, and her top priority is ensuring that all children can get the best possible treatment as early as possible. We always ask our speakers to say something about, like, how did you get passionate about this? And she says that she got passionate about health equity and access when she was living in Kenya, where stark disparities are part of daily life. And with this lens, she has been examining the way structural factors impact patient outcomes. And she does this through her research, but she also has a number of leadership positions. She's the Vice Chair for Diversity and Health Disparities in the Children's Oncology Group, and serves on the Diversity, Equity, and Inclusion Committee for the Helen Diller Cancer Center. And with that, I'm handing it over to Dr. Weinstone.
All right, thank you for the lovely introduction. I'm trying to get my slides pulled up properly for you guys, so hopefully you're seeing the right thing. Does this look right, or do I need to swap them again?
We see presenter view. You might want to.
Yeah, let me swap it. Sorry, guys. One sec, we got this all figured out. And now I'm.
Beautiful.
All right. Thank you for the introduction. I actually am honored to be included in the Equity Month specifically, and really have been listening with excitement to everyone else's presentations on this topic. I think it is such a sort of pertinent and salient area. It's work that I've been doing for over 10 years now, but it is becoming increasingly prominent. And as a result, I'm really excited to share the work we're doing within pediatric oncology, specifically trying to understand barriers to health equity. So to start off, I'll provide a little bit of background about pediatric cancer. About 14,000 children and adolescents per year are diagnosed with cancer in the United States, and that comes out to about 1 in 285 over childhood in terms of the rate of pediatric cancer. So it's relatively common when we're talking amongst rare pediatric diseases. And despite what some people may think about sort of pediatric cancer being a relatively difficult field to work in, 80% of children with cancer are cured, and that's been through tremendous progress over the years. in spite of that progress, it is still the leading cause of disease-related death among pediatric patients age 0 to 14. And so essentially the only thing that leads to more deaths in our population is accidents. Leukemia, as many of you know, is the most common form of pediatric cancer. And that's really where I'm going to focus. Most of my attention today is on pediatric leukemia. We'll sort of use it as a case study. I think that the lessons we learn within pediatric leukemia are translatable to certainly other pediatric cancers, potentially to adult cancers, but also to other pediatric chronic diseases. And so I think that hopefully some of the information that I share here is sort of pertinent to patients who deal with complex diagnoses, as well as prolonged and complex treatment, issues with adherence. I think all of those things are hopefully somewhat universal to other chronic diseases within pediatric oncology. So the next slide I'm going to show you, I'm going to warn you in advance, is unlabeled, and that is intentional. It is a Kaplan-Meier curve. And so I'll first sort of explain how we interpret these graphs for those people who aren't used to looking at them very much, because you'll be seeing a lot of these throughout the presentation. Along the x-axis here, we have time, and it's usually in years. We're very frequently looking at 5-year survival in our patient population, so often to this sort of 5-year point right here, but this graph actually goes out to 10 years. Then the other thing you'll see is that along this axis, it's almost always a percentage, 0 to 100% survival. And so if everyone survived, you'd see a straight line across the top. And if everyone died, this line would come all the way down to 0. And typically you'll see something in between. And so just want to orient everyone to that. I think a lot of people are looking at this and kind of wondering, well, what are we looking at here? And because this is something we look at very frequently in pediatric oncology, you know, these lines could represent a variety of different things. They could represent different diseases. So I told you we were going to talk about ALL and AML, which are the two most common pediatric leukemias, and maybe one of these represents ALL and one of these represents AML. Or maybe these represent a biologic feature of the disease, like high-risk disease versus low-risk disease. So I want everyone to sort of take a second and maybe take a guess at what this is. You guys know my topic is disparities. So that should be a hint. You can feel free to put something in the chat or Q&A to kind of put down your nickel before I move on to actually telling you what it is. All right, so this represents a 25% difference. This is we're not talking about a relative difference. This is an absolute difference in survival. So we're talking that 25% fewer patients survive in that bottom green curve relative to that top sort of turquoise curve. And so when we move on, this is a pretty stark disparity, and it's related to the neighborhood that people live in. And you guys have probably heard the saying that your zip code is more important than your genetic code. I think that dogma is probably not as well accepted in pediatric oncology, but part of the focus of my work is really to try and help people understand the role that social determinants of health play. And here we can see that on this top line, middle and high income patients have a 68% overall survival after a diagnosis of acute myeloid leukemia. And this is in the setting of treatment on a clinical trial, compared to those that are living in poverty, which have a 43% overall survival. And then this low income group, which is we defined here as patients between the sort of federal poverty line and 200% of the federal poverty line, had significantly different overall survival relative to that middle and high income population as well. And so really that's where I'm going to focus the rest of this talk. My overarching goal for my research is to investigate the role that race and ethnicity, as well as socioeconomic status, play in contributing to pediatric oncology disparities and outcome. We'll take a step back and just make sure we're all starting from the same place in terms of terminology. Health disparities, I think everyone is probably familiar with this term, but they represent systematic and avoidable health differences adversely affect socially disadvantaged groups. And it's really important to recognize that not all health differences are disparities. In fact, there's a requirement that they arise from intentional or unintentional discrimination or marginalization of a group and are likely to reinforce social disadvantage and vulnerability. And health equity is the principle underlying a commitment to reducing disparities in health and its determinants. It's essentially social justice in the arena of health. I want to also talk about race for a moment because it is one of the determinants that I'm looking at frequently, and really define it here as a social category. It's a composite of a whole bunch of different things, and it includes socioeconomic and political influences. And it's very distinct from genetic ancestry. And I think a lot of times people think of them as intertwined, and there certainly is some overlap, but we know that it's a poor proxy for genetic ancestry, and that the boundaries between genetic ancestry don't line up perfectly with someone's self-reported race. And so as a result, we're moving further and further away from using race as a proxy for genetic ancestry. And one of the unique things about oncology is that we have so much genomic data as well as genetic data on our patients that we have the opportunity to really tease that apart in greater detail than a lot of other fields. And then the last, socioeconomic status, is again a very complex construct reflected by income, education, and material hardship, or sort of the inability to meet your basic needs with the resources you have available. In pediatric oncology, we'll often be talking about it at the neighborhood level. And that is because we don't systematically collect individual level data around socioeconomic status. And then in addition, we'll often use health insurance as a proxy for income because of the means testing component of insurance. Okay, so another step back, I'm going to just give you a little bit more background about pediatric oncology. And these are those famous Kaplan-Meier curves that you're going to be seeing throughout the presentation. You can see here that basically through systematic clinical trials, acute lymphoblastic leukemia, which is the most common form of leukemia, we've made tremendous progress in the last 40 years in terms of improving outcomes for patients. So back in 1970, when one of these first trials was sort of put together, we see that outcomes were around 10% at 5 years for patients with ALL. And progressively over time, with each subsequent trial, additional therapies were added. And there was a big jump when we made progress towards using multiple different drugs simultaneously. And continually over time, basically several institutions across the country, many of them got together and said, this is a rare disease, and the only way we're going to make progress is by collaborating and putting our data together and systematically testing new therapies. And so this really is one of the success stories of the modern era in terms of going from a 10% survival to greater than 90% overall survival. And I will say that this has not been true for all diseases, even those treated within the children's oncology group, but ALL in particular is one where there's been a really remarkable level of success. So the Children's Oncology Group is largely responsible for that progress. It's a cooperative group of clinical trial that offers clinical trials. It's funded by the National Cancer Institute. And at any given time, they have approximately 100 studies open and running to try and improve therapy across pediatric oncology. You'll see the sites here on the right in this graph, and they are distributed across the United States. You will see some notable areas where the population is thin, and there also are not centers. So that's one important thing to note. In addition, you'll see that among these 200 sites, more than 90% of children with cancer are treated at one of these sites. But I will note that being treated at a COG site does not necessarily mean being enrolled on a clinical trial at that site. And that's another really important component. Last thing I'll say about this is that when I said that I was interested in doing disparities work within pediatric oncology at the start of my career, many said, we have the Children's Oncology Group, we have these protocolized approaches to treating patients, we really don't have disparities within pediatric oncology. And you'll see that I've spent the last several years trying to demonstrate that that is not the case, that despite this amazing infrastructure and the amazing progress that's been made, that progress has been unequal and not equitable. And so we'll work towards improving that. So the next thing I'm going to introduce is something called the Pediatric Health Information System. This may be more familiar to some people in the audience because it includes patients both with oncologic diagnoses, but also any patient treated at a freestanding children's hospital. And there are 53 participating hospitals at this point. You can see again that many of the sites overlap with Children's Oncology Group sites. And the data set contains administrative and billing data. So it doesn't contain clinical details, but contains information about every encounter that is in the inpatient setting. And so we leveraged this data set combined with Children's Oncology Group data to look at clinical trial enrollment. And the way we did this was we merged the two cohorts. So we designed a cohort of patients with acute myeloid leukemia based on the receipt of chemotherapy. We restricted that to COG institutions, and you can see that really only about 40 patients fell out because the majority of patients are treated at a COG institution. We then restricted it to time periods when there was IRB approval at that specific site for the most recent AML clinical trial, which is called AAML 1031. And that was a substantial restriction that brought us down to about 370 patients. So among the 370 patients in our cohort within FIS, we matched them with patients in COG and found that 206 of them were enrolled on the clinical trial, and those that we were unable to find in the COG cohort were therefore defined as not enrolled for the purposes of this study. And what we found is consistent with our hypotheses and consistent with adult literature, Black patients are less likely to enroll on this particular clinical trial, with 60% enrollment amongst white and Hispanic patients and 30% enrollment amongst Black patients and those of other race. So when we incorporated this into a multivariable model that took into account area-based socioeconomic status, as well as other measures like insurance status and age of diagnosis, we found really not a substantial change. Black patients remained 50% less likely to enroll on this clinical trial. And so I wanted to start with this because I think that as we think about the Children's Oncology Group and the strength of that approach to treating patients, we have to remember that not everyone has access to the opportunities that type of approach to treating patients allows. So the overview for the rest of the talk is really going to focus on the contributors to survival disparities, and I've sort of divided it into 3 different categories to mimic the continuum of cancer care. This is adapted from the Institute of Medicine report on delivering high quality cancer care that divides the phases of treatment for patients into the diagnosis and presentation, so initial, even prior to receipt of chemotherapy, the period where you're receiving upfront treatment, and then the period after treatment, which can be in the setting of the cancer coming back, relapsing, and eventually potentially no longer being able to be treated and leading to end of life, or patients who go on to require long-term follow-up because we know that the chemotherapy as well as the cancer itself lead to long-term effects that require lifelong management. So in this first category, a lot of these are sort of baseline characteristics, some of which we've already talked about and that I'll talk about in greater detail. The olive ones in purple are things that I'll be planning to talk about today. So race, ethnicity, language, neighborhood, socioeconomic status, rurality, social support, primary access to primary care, acuity or how sick a patient is at the time that they come to the hospital, molecular profiling. And then things that we haven't evaluated yet that are on the radar to look at in the future include health literacy, as well as general literacy and education, comorbidities, and stage of diagnosis. In the next category, once a patient is ready to start treatment, things that might impact their outcome include the disease biology and the histology of the tumor itself, the location where they receive care, whether they're enrolled on a clinical trial, which, as you can see, we've already talked about. Chemotherapy, radiation, and surgery are the main modalities we use to manage these patients, and the subsequent toxicity that comes from that, as well as the financial toxicity that comes from that. And we'll unpack that term a little bit more, but we know that a cancer diagnosis leads to pretty substantial impacts on a family's financial situation. Pharmacogenetics have an influence, as well as adherence to therapy and the supportive care that goes along with the complex therapies we provide. And then finally, in the post-treatment period, my clinical focus is actually in stem cell transplant. I'm in the division of allergy, immunology, and bone marrow transplant. And so because of that, really, I'm going to focus in on bone marrow transplant as a salvage or sort of therapy for those with high risk or refractory disease. Other things that happen in the period are sometimes patients receive targeted therapies, salvage therapy. They potentially enroll in a second clinical trial or a third or a fourth, as well as survivorship care and the risk of late effects, which can ultimately also be life-threatening. So that's the overview for today. The last piece that I'll talk about is health insurance, which I didn't put in any one of these boxes. I initially had it under the sort of diagnosis and presentation category because I think we think of it as influencing whether and how a patient gets diagnosed, but it actually has influences across the continuum of cancer care. And so we'll look at it from that perspective at the end of the presentation. So focusing in on this first box, disparities of diagnosis. This is work done in collaboration with one of my mentees, a medical student, Lucky Ding, who actually just submitted this for publication. And what we did here was we really wanted to start with the patient perspective and understand what the pathway to diagnosis looks like, with the idea that at the time of leukemia diagnosis, because we don't stage leukemia in the same way as solid tumors, how sick a patient is when they come in the door may be a predictor of this path to diagnosis, or maybe linked to this path to diagnosis. And so the need for ICU resources in the first 72 hours is something I'll refer to as acuity or acuity of presentation. And we have demonstrated that this measure is very closely linked to mortality. So if you go to the ICU within the first 72 hours, you have a 17-fold risk of death within the first month after diagnosis. So to define this path to diagnosis, we did in-depth interviews with 32 patients, including 5 Spanish-speaking patients here at UCSF. And several themes emerged. And so I'll draw your attention to them over here in this column. One of which is that because it is, a set of vague symptoms that come up in leukemia, there often were physician and parent disputes or tensions around the diagnostic process. A lot of patients reported difficulty getting in to see their primary doctor or to see any doctor. Parents also reported that their experience with healthcare in the past often facilitated their ability to advocate for a child. And then implicit bias did come up in several cases, particularly among young mothers. There was a lot of sort of difficulty and concern that their judgment may not be questioned, their judgment was questioned. And then the last box that I'll focus in on is this financial and insurance concerns. So one patient said that urgent care, I believe, is $25 or $50 through insurance, and ER is $500. It dissuades people, and it sounds so ridiculous because it's your life. So this family was specifically speaking about their choice to go to urgent care rather than the emergency room. And in this study, we demonstrated that patients are much more likely to have blood drawn in the emergency room than in urgent care. And so that influences the timeliness of a diagnosis. Similarly, another family said, we have a high deductible insurance plan, so we do tend to be a little bit slower to get care. I would say that if we had an insurance plan that didn't kind of penalize us for using it, we would probably be a little quicker. So the next thing we did was we actually used a private payer insurance database to look at sort of time to diagnosis. And we defined anything more than 3 months of symptoms as being a prolonged time to diagnosis. And looked at sort of a variety of characteristics, but specifically the one that I'll highlight here is that families who make less than $40,000 a year have a sort of 20% higher odds of being found to have prolonged time to diagnosis. Interestingly, we didn't find that among patients with private insurance that race ethnicity had a major impact, but I will highlight, since I'm talking to a general pediatrics audience, that relative to primary care, if a patient initially presented to a specialist, this actually made them more likely to have prolonged time to diagnosis. And this could be, a component of how complicated it is to make the diagnosis, that they initially presented to a specialist. We have stories of patients who, for example, went to a dentist for bleeding gums as their initial presentation of their leukemia. And so it may not be anything specifically about the specialists themselves, but I did want to put in a shout out to primary care here that that depending on where patients present, we do see differences in the timing of their symptoms. So now I'll move on to something called induction mortality. And induction mortality refers to that early mortality or death within the first 50 to 100 days after a new diagnosis. And so within AML, we specifically looked at Black children and found that they have double the risk of early death. So about 5% of Black patients will die in the first 50 days after a new diagnosis of AML, where only about 2% of white patients will die during that same time frame. And so to unpack that a little bit further, we looked at that measure of acuity of presentation. And we can see here that we also looked at it in the context of insurance. And when we look with combining or stratifying by insurance and race, this top line, this blue line, is white patients with private insurance. This red line is Black patients with private insurance. And this green line is white patients with public insurance. And you can see that all of their outcomes are relatively similar to one another, but Black patients with public insurance have substantially worse outcomes. And I want to bring this up because it shows that Black patients and white patients can have pretty similar outcomes when they have similar insurance, and really, I think, points away from biology as the main contributor here, because if it were biologic, it doesn't seem like insurance would have a close relationship with disease biology. And so this really helps us to think through where we should be paying attention to this disparity and how we can start to think about the mechanism of this disparity. So here, when we look at acuity of presentation, this line here shows us patients who had multi-organ system failure or needed, for example, mechanical ventilation and renal replacement therapy. And that's about 10% of Black patients with AML at the time of diagnosis and only 3% of white patients. So a threefold risk of multi-organ system failure at the time of diagnosis amongst Black patients. And furthermore, when we look at need for any ICU level care, so just mechanical ventilation, for example, or leukapheresis at the time of diagnosis, we find that 17% of Black patients with AML needed ICU level care and 11% of white patients needed that same level of care. Interestingly, this last line, we actually adjusted for acuity in a multivariable model. And after we adjust for that first 72 hours after diagnosis, we see the effect go away, meaning that after that first 72 hours, there's not a substantial difference in the need for ICU level care between Black and white patients. And this, again, really points to something happening prior to diagnosis that makes these patients sicker when they come in the door of our hospital. I want to highlight that the findings that I've just shown you within AML translate to other hematologic malignancies. So this is just a sort of recapitulation and unadjusted demonstration of the same finding. And when we look in ALL, the other type of leukemia, we see very similar point estimates with, again, about a 60% higher risk of need for ICU at the time of diagnosis and a threefold increased risk of multi-organ system failure at the time of diagnosis. And then finally, we looked at non-Hodgkin's lymphoma. And you can see that we have smaller numbers here and that the prevalence of need for ICU is actually higher than it is in ALL, but we again see very similar relationships where Black patients have a higher need for ICU at the time of diagnosis and at least a suggestion that they are more likely to have multi-organ system failure. So we went from using that administrative data to start to answer that question to really wanting to dig into the more clinical side of things. And so using electronic health data from the Children's Hospital of Philadelphia and Texas Children's Hospital, we actually looked at the labs at diagnosis for Black patients compared to white patients. And about a quarter of patients with AML will present with a white count over 50, which is something we know is prognostic in terms of their ultimate diagnosis and treatment. And we found that Black patients, again, have a twofold increased risk of presenting with a white count over 50. Similarly, uric acid, which is released from cells as they break open and is another measure of disease burden at the time of diagnosis, was twofold higher in the Black population, despite it being substantially less common than a white count over 50%. And when we looked at organ function, including liver function and creatinine, we found similarly a twofold increased risk amongst Black patients relative to white patients. And as another sort of attempt to get at this multi-organ system failure, Black patients were more likely to have more than one organ system involved as well. And then the last point that I want to make about this is just that while we do see that in addition to a twofold risk for a white count above 50, we also see that the median white blood cell count at diagnosis is about double amongst Black patients relative to white patients, but that within 5 days of starting chemotherapy, they've come down to the same place. And that suggests a similar level of responsiveness to chemotherapy, and really that after the initial diagnosis, we're able to get patients into a similar place. And this is corroborated by work that we did when we looked at patients outside of that first course of treatment called induction in their other treatment courses, and found that Black patients have very similar receipt of therapy and receipt of supportive care like antibiotics and antifungals. So here I'll talk about some work that I've done since coming to UCSF, working with the Greater Bay Area Cancer Registry. I showed you already a little bit, and I'll get into greater detail about it, within the context of clinical trials, that socioeconomic status seems to have an impact within AML. And when we look at it in a sort of more complex ecosystem of patients' neighborhoods, so incorporating aspects of the social and built environment in addition to sort of basic measures of socioeconomic status, we use something called the latent class analysis to design 9 neighborhood archetypes that are sort of specific to California. And based on this map, you can see this sort of rural micropolitan areas, the purple. This red represents Hispanic small towns, largely in the Central Valley. And then we get into sort of some of the coastal regions where we see high status and upper middle class suburbs. And just to help people conceptualize them a little bit further, when we look explicitly within San Francisco, our area is considered like a new urban pedestrian in Mission Bay. And you can see that we do have some upper middle class suburbs out on sort of the western side of the city. And this area is considered a sort of suburban pioneer area. So hopefully that gives you a little bit more of a sense of what these archetypes represent, to give you a little bit more granular detail about what went into each of these archetypes. I'll just take a couple of examples. Again, sort of Hispanic small town would be a pretty straightforward one where the population is largely Hispanic, and the socioeconomic status is sort of lower to middle, and the food resources in the area tend to be generally unhealthy. When we look at the inner city, again, not surprisingly, this would be sort of consistent with what you would expect. Some of the more sort of less common terms that might be harder for people to understand would be something like a suburban pioneer, which generally is a middle SES kind of within a city, a very diverse population, and the families and typically own their homes in the suburban pioneer kind of category. So we looked at survival in relation to these archetypes and found pretty substantial and stark disparities. So you can see here, in particular, I'll highlight these bottom 4. The inner city for both ALL and AML was a predictor of outcomes for patients. And similarly, the mixed SES class suburbs showed statistically significant categories in both. Because we're getting into sort of smaller number, we don't see these to be statistically significant. In other words, they include 1, but the magnitude of effect, about a 30% increased risk of mortality, is there for both Hispanic small towns and suburban pioneers within AML, and we do see statistically significant differences in Hispanic small towns and suburban pioneers within ALL. In general, a lot of these sort of lined up with one another, but I will highlight that the rural micropolitan group, really we only saw differences within the ALL population and not the AML population. And for those familiar with treatment, this might make sense because AML is generally treated in an inpatient setting. And so someone who lives distant from a healthcare facility gets admitted for potentially, a month at a time, and there is no outpatient therapy typically, versus ALL, which is treated over a 2 to 3 year period with multiple outpatient visits and need for prescriptions and adhering to medication regimens. And so we hypothesize that that may contribute to the differences we're seeing between AML and ALL here. All right, so to summarize what we've talked about within disparities at diagnosis, we think that income, finances, and insurance are barriers for patients to receive care in a timely diagnosis. Black race is associated with higher disease burden at diagnosis for AML. It is associated with higher acuity across hematologic malignancies, and it is associated with early death within AML. And then when we look at neighborhood as a predictor, and that's where we're incorporating things like rurality, as well as socioeconomic status and race ethnicity, we find that kids from inner cities, mixed suburbs, and Hispanic small towns have worse survival than those who live in a what we call high status or high income neighborhood. All right, so to move on to the next category, which is patients on treatment, we're not going to be able to talk about all of these factors, but we'll focus in on a few of them. So The first is, you guys may be familiar with a test that came out in about 2015 here at UCSF called the UCSF 500. It is essentially next generation sequencing and CLIA approved. It covers about 500 genes, some of which are predictive of, prognostic towards outcome, and some of which actually can help identify drugs that could be used to augment the therapy we provide. But we identify single nucleotide variants as well as indels and copy number changes using this test. And so it's a test that theoretically can inform the therapy we provide patients, and we wanted to evaluate how access to this approach is being offered at UCSF. And this work is done by a medical student, Colin Wong, who actually just presented these data yesterday at the American Society of Pediatric Hem-Onc virtually. And so we looked at the leukemia population, and our leukemia population here is largely Hispanic and publicly insured, and majority of them were MRD negative or had no measurable residual disease at the end of induction or that first course of chemotherapy that I was describing to you. And many of them have high-risk disease. And what we found was that neighborhood income was a predictor of receipt of this testing. We also found that English language was a very strong predictor. And then sort of lending face validity to our analyses, it looks like the biggest predictor of whether a patient had this testing performed was measurable residual disease at the end of induction. And it is frequent that we find that if a patient doesn't respond to chemotherapy as we expect, or is not in remission at the time of the end of the first course of treatment, we start to wonder if there's something unique or special about their leukemia, and as a result, we'll do additional testing. And so this model also included race, age, risk category, insurance, language, education, income, and year. And we did see that year over year, we are increasing utilization of this testing. And so my hope is that as the uptake of this testing improves, these disparities will narrow. But I think another approach to addressing this would be to put pretty clear guidelines into place in terms of who is tested. So the next thing that I'll share is going back to that figure that I showed to start off with, which is, again, that patients with AML who are living in poverty or live in a low-income neighborhood have worse survival. In addition to the overall survival curve that I already showed you, I'm showing you here the event-free survival. And when we talk about event-free survival, events are typically defined as relapse or sort of recurrence of disease. And so typically, we see that event-free survival is lower than overall survival because any patient who can be salvaged or sort of treated with something, for example, like bone marrow transplant that then prevents their disease from coming back a second time, is able to survive overall, but did experience relapse. And we see this very similar relationships for event-free survival, which again suggests that low-income patients are more likely to relapse. And this has been pretty well documented within ALL previously, but has not been shown within AML. And in ALL, it's been largely attributed to adherence, but as I alluded to before, AML is treated almost entirely in the inpatient setting. And so we don't think that adherence could be playing a role in AML. And so trying to understand what the differences are in this patient population that would contribute to these disparate outcomes is a big part of the work that I do. Specifically, when we look at income, higher income children have a 27% lower risk of dying. And then in addition, racial disparities have been well documented in the last 4 clinical trials that have been performed. And so far to date, prior to this study, no one had looked at socioeconomic status. And so even when we account for area-based socioeconomic status, the racial disparities also persist. And that implies that we need additional investigation into those two things and need to continue to tease apart where they may overlap and where they may have separate mechanisms. In addition to looking at relapse, which I already talked about, we also looked at treatment-related mortality. And so this gets to sort of this question of treatment toxicity. If we're delivering, this is in the setting of a clinical trial, if we're delivering the same chemotherapy to patients, are we seeing differences in the leukemia response? The answer is yes. Are we seeing differences in the toxicities associated with that chemotherapy? And I should note that these are unadjusted because we're still working through these models, but what we found here is that those who live in a middle or high income neighborhood have about 4% rate of treatment-related mortality. And among the low income population, we see an 11% rate of treatment-related mortality. So very substantially increased treatment toxicity amongst low-income patients. The next thing I'll move on to is something I alluded to earlier, financial toxicity. It may be a term that's less familiar to those outside of oncology, but refers to the same types of treatment effects or diagnosis effects that impact your financial situation. And just to provide some background, 94% of families with a cancer diagnosis report some level of work disruption. 30 to 50% of families report that one parent had to quit their job to care for their child with cancer. And 12 to 16% of previously higher income families fall below the cutoff of 200% of the federal poverty line after a diagnosis. So our objective was really to look at this within the UCSF patient population in Mission Bay and Oakland. And when we looked at something called household material hardship, which again essentially means that you are unable to meet the basic needs of your family with the resources you have available, at baseline or at the time of diagnosis, we found that 17% have housing insecurity, 11% have food insecurity, 7% have energy insecurity, and about a quarter of our patient population is reporting one or more of these. When we looked 12 months after diagnosis, we saw a remarkable increase, and this is notable. It has been previously demonstrated in the Boston area, and we're seeing very similar effects here with 25% of our patients experiencing housing insecurity, 25% experiencing food insecurity, 21% energy or utility insecurity, and 41% having one or more categories of insecurity. And I think, this is, pretty stark and remarkable and really should inform the care we provide our patients. If a quarter of the patients we're prescribing chemotherapy to don't have enough food at home, it's not surprising that we see differences in outcomes for patients. So the last thing that I'll note, because this is a little bit sort of depressing, is that we did find that when we scored social support, those who had higher social support scores had a decreased odds of experiencing household material hardship by 80%. And so that does seem to be a protective factor that may allow us to start to ameliorate or mitigate these effects in the future. This work is performed by Erica Evans, one of our very own third-year residents. And she also looked at something called cost score, which is a way of measuring financial toxicity. And we looked at it by income category. And what we found is that those that we defined as high income or making more than 400% of the federal poverty line had higher cost scores relative to those that we defined as low income who had lower cost scores. And I should note that a lower cost score represents higher financial toxicity. And so there were statistically significant differences between high and low income populations in terms of the risk of financial toxicity, perhaps not surprisingly, but important to demonstrate so that we know how to appropriately target our interventions. We did also look at work flexibility as a contributor, and at this point haven't found any relationship, but we are continuing to recruit patients for this study and specifically trying to incorporate more Spanish-speaking patients into the study population. So stay tuned for these results because they're sort of still in progress. So I'll pause there and sort of summarize what we found with those undergoing treatment, which is that from the very beginning, Black patients are less likely to enroll on clinical trials for therapeutic medications, that minorities, low SES and limited English proficiency have decreased molecular testing here at UCSF, and that treatment among those receiving treatment on a clinical trial, we see lower survival, higher relapse rates, and higher rates of toxic death along the lines of neighborhood SES. And then finally, that we see greater financial toxicity among low-income families. So substantial disparities on treatment. And we'll move now to talking about bone marrow transplant as sort of, again, a case study of what happens after the initial treatment period. So just to provide a little bit of background on bone marrow transplant, it is a mainstay of treatment for high risk and relapsed leukemias, with about half of AML patients coming to stem cell transplant. And it requires donation of stem cells from a family member or an unrelated donor. And this is a little bit where the disease biology impacts which patients will need this therapy, but then in addition, there are components of genetic ancestry that impact the availability of donors. And so part of why I really wanted to sort of tease apart the differences and between race, ethnicity as a social construct and genetic ancestry as a measure of genealogy. And so we know that 19% of Black patients will find a matched unrelated donor, which is substantially less than what we find amongst the minority or white population. And that translates to minority patients being 65% less likely to have a suitable unrelated donor, and results in Black patients being about 50% more likely to receive what we call a haplo or half-matched transplant from a relative. And this has implications for their risk of developing something called graft versus host disease, as well as the ability to control the leukemia. And some patients end up not even receiving transplant because we're unable to find a suitable donor. That is becoming less and less of a problem as we are moving towards this approach of haplo donor, what we call alternative donors, as an approach to treating patients. And so over time, I think this is becoming less and less of a problem, but has historically and in the data that we are looking at been a problem for a minority patient population. So we decided to look at this using California Cancer Registry data. We defined a cohort of leukemia patients to assess access to stem cell transplant. And among these 7,000 patients, we will highlight that there were differences amongst the Hispanic and Black population in terms of being in the lowest quintile of neighborhood SES, as well as rates of public insurance, with about 56% of Hispanic patients having public insurance and 46% of Black patients having public insurance. And you'll see that that's very consistent with the demographics of our state. So of these 7,000 patients, 21% of them underwent a stem cell transplant. And as we hypothesized, Black patients were less likely to receive stem cell transplant, as were those who had no insurance. And we thought that public insurance might impact the receipt of transplant, and I'm happy to say that it doesn't impact the receipt of transplant, but patients who had no insurance were 80% less likely to receive a transplant. Again, lending face validity to our results, we found that those with AML are more likely to receive a transplant relative to those with ALL. And we were very surprised to find that actually the Asian Pacific Islander population within the state of California is 25% more likely than the non-Hispanic white population to receive transplant. And whether this is related to something about their need for transplant or their availability of donors or something else we have yet to investigate. This is, again, ongoing work. The next thing we looked at is that after demonstrating that there is a disparity in receipt of transplant, what happens to those patients after transplant? And we looked at several measures of resource utilization, the first of which was the initial admission for transplant. These are definitely prolonged transplant admissions in general, with most the white non-Hispanic population staying in the hospital for about 35 days. But we found that Hispanic patients were staying in the hospital for a median of 39 days, and Black patients were staying in the hospital for a median of 49 days. Similarly, when we looked in the days in the hospital outside of the initial transplant admission in the first year, we found that Hispanic patients spent a median of 11 days compared to 7 days amongst the white population. And when we look at the number of patients being readmitted more than once after that initial admission, we find that that's only 25% of the white population and 32% of the Hispanic population. So it does appear that there are increased complications, but these data didn't allow us to get at the details of those complications. Further data from something called the CIBMTR, which is a registry across the country looking at how poverty impacts outcomes for our transplant population. We see that those who live in high poverty neighborhoods, and this is becoming perhaps a familiar story after listening to me talk for a little while, we see that there's higher toxic mortality or treatment related mortality amongst those living in high poverty neighborhoods, with 25% cumulative incidence of mortality amongst the high poverty relative to the low poverty neighborhoods, which had a 20% toxic mortality rate. So just to summarize what I've told you about bone marrow transplant, Black and uninsured patients are less likely to receive transplants to begin with. And then following transplant, Hispanic and Black patients have longer lengths of stay and more readmissions. And then finally, poverty is associated with increased toxic mortality. So the last thing I'll focus on is insurance, and that is sort of across the cancer continuum. So again, just to provide a little bit of background here, we often use insurance as a measure or proxy for socioeconomic status in pediatric oncology because we don't have detailed information about individual socioeconomic status. And this is essentially why. It's a means tested insurance. And so among those who are, make less than 100% of the federal poverty line, we see that 73% of them have Medicaid. And so if we combine the Medicaid and uninsured patient population, we're really capturing a pretty large swath of the what we would call poor patients. And you can see that as you go up in your income, you are less likely to have Medicaid, perhaps not surprising again to anyone in this audience. We also see, and this is similar to what I showed you within our California Cancer Registry data, that Hispanic and Black patients are much more likely to have public insurance than their white and Asian counterparts. So this work was done by a graduated fellow now, Neela Penyamurthy, who's practicing over in Oakland. And when we looked at our sarcoma population here, we found that 39% of them had public insurance and that the overall survival was 66%. And we saw that there was a stark disparity in terms of outcome related to insurance. So 71% overall survival amongst the privately insured patients in this solid line, and this dotted line represents those with public insurance. And we see that the outcomes are substantially worse in that patient population. Because sarcoma is a solid tumor, I wanted to include it here just because we are able to look at stage, which is often in adults a big predictor of how income and race ethnicity impact outcomes is via stage. And we actually did a mediation analysis and found that stage was not the explanatory variable in terms of explaining why public insurance patients have worse outcomes. We see here that when we look at among those with localized disease, we see still an outcome disparity with 84% overall survival amongst those with private insurance and 78% overall survival amongst those with public insurance. Similarly, those with regional disease, meaning potentially lymph node involvement, we see similar level of disparity. And finally, among those with metastatic disease, we continue to see statistically significant differences among those with private and public insurance. And so again, bears additional investigation, but this is specifically in a UCSF cohort, we see disparities by insurance status. Similarly, when we look at patients following stem cell transplant, so patients with neuroblastoma get something called an autologous transplant, meaning they receive their own cells back, and after that they receive immunotherapy, which is a targeted therapy against the tumor itself. We see differences both in event-free survival and overall survival, which suggests that insurance is playing a substantial role, whether it's insurance itself or using insurance as a proxy measure for income. Bears additional investigation, but these are patients enrolled in a clinical trial who are receiving consistent therapy and are some of our best players because they've made it to sort of the final stages of treatment. They've survived transplant, and we still see substantial disparities at that phase in treatment. We did another analysis where we looked at the interaction between socioeconomic status and insurance. So we used insurance as sort of a household measure, and then we looked at neighborhood level poverty and found that those who live in a neighborhood without poverty and have private insurance have 90% overall survival relative to those who we are considering dually exposed, meaning they live in a high poverty neighborhood and have public insurance with 64% overall survival in that patient population. So the very last thing I'll talk about is the Affordable Care Act and the role that it may have played in pediatric oncology. And just to very briefly give an overview of the impacts that it might have on our specific patient population, there's something called the dependent care provision, which allowed patients to stay on their parents' insurance from age 19 to 26. It also prevented patients with pre-existing conditions from being difficult to insure. There was a Medicaid expansion that generally applied to adults, but had impacts on kids because we know that there's a welcome mat effect where once a parent gets insurance through Medicaid, they often also, if their child was not already on Medicaid, add them to Medicaid. And then it also impacted annual and lifetime limits on payments. So what we can see here is we did a study within a private payer insurance database to look at the impact of the Affordable Care Act and did a difference in difference analysis where we looked pre and post the Affordable Care Act. And what we see here is that younger and older patients had similar rates of disenrollment, with these two lines being generally overlapping. And when we look here after the Affordable Care Act, younger patients were less likely to disenroll from their parents or from insurance. And we presume that's because they stayed on their parents' insurance. And this led to less insurance churn, which we know has implications for our pediatric cancer population because insurance churn leads to difficulties and gaps in care. So with that, I will sort of sum everything up for you and talk about where we go from here, which is that we think of disparities work in 3 phases: detecting, defining, and measuring disparities, understanding disparities by trying to look at the mechanisms, which is really where I've dedicated most of my effort. And the last is to reducing disparities, evaluating interventions for health disparities. And that's really where we're quite far behind, I think, relative to general pediatrics and the work that's being done there. There are relatively few interventions to address these disparities. And I think that the Children's Oncology Group represents a tremendous opportunity to sort of leapfrog over, because we have such great infrastructure in place. And so the first step is really collecting detailed information about social determinants of health and individual socioeconomic status. And we have the infrastructure in place already to do that. The next would be applying our precision medicine techniques to population health to identify these mechanisms. And then finally, because we have such a robust clinical trial infrastructure, we have a unique opportunity to evaluate interventions in the context of already standardized therapy and collaborations that already exist. And so I would argue that pediatric oncology is sort of poised to address disparities in a unique way relative to other fields. So just to summarize, these disparities are pervasive and span the cancer continuum. Hispanic patients, Black patients, those that come from low-income areas and those with public insurance present sicker, have more complications, relapse more frequently, and have greater financial hardship. And finally, our existing protocolized approaches to treatment and infrastructure for clinical trials present a unique opportunity within pediatric oncology to address disparities. So with that, I'd like to thank my many mentors and collaborators, as well as my mentees who have completed a lot of this work, as well as the funding agencies and patients. I'm honored to be speaking here, and I'm happy to take any questions at this point.
Thank you so much, Dr. Weinstein. There was a wealth of information and a lot of good work that you're presenting here, and clearly still a lot of work that needs to be done. We have just a couple of minutes for questions, so if anyone has them, please put them in the Q&A. I see one question on the Q&A, which I think goes back to the timing you're talking about AML. Can you see the question? It says, can you please define indels?
I guess so. Indels refer to basically deletions within, so it's one specific way of looking at the genetic makeup of the cancer or genome of the cancer. And basically, there are several different ways that we look at mutations within pediatric cancer. Within pediatric cancer relative to adult cancer, for example, we see many more fusions. And so our profile in particular is designed to evaluate things that you often can't find in commercial testing, and one of which is indels.
Thank you. I do not see any other questions coming up during the Q&A, and since we're almost at the hour, oh wait, a question. Can UCSF 500 data inform ancestry?
That's a good question, Ben. I think that most of the approaches to looking at genetic ancestry have used, for example, whole exome sequencing that I'm familiar with. I don't know. I imagine that there might be ways to do that, but I think it would take some additional thought. I think the fact that we collect germline DNA in a subset of patients would make it possible to do additional analyses to actually look at genetic ancestry.
Thank you. And then we have one last question. Do you have any other theories for these disparities, specifically worse survival with public versus private insurance?
Yeah, so I did specific training in health policy, and so a lot of my interest lies in thinking about public versus private insurance. And I think it, just like everything else I've talked about, is very multifactorial. And I don't think that we really can say that Medicaid is inherently worse insurance. That's certainly not the message I'm trying to send here. But I think it is a proxy for so many other things. One of which, that does speak to the difficulties with Medicaid is that, particularly at the time of diagnosis, fewer providers accept Medicaid. And we also know that, for example, in the receipt of precision medicine and very highly specialized therapies where patients sometimes have to travel for care and cross state lines, it can be quite difficult to use state Medicaid to cover that type of care. And so I think, there are many, many layers to the ways that insurance impacts outcomes for our patients. And those are just a couple, but I think that we need to continue to dig deeper into that.
Thank you very much. It's one after one. So I'm going to ask Dr. Hurst to wrap it up for us.
Well, thank you, Dr. Weinstein. That was really excellent work and very important topic and very impactful in terms of the implications for our community and the children we care for. So I want to thank you again for sharing your work with us. And I'd like to thank everybody for participating today in Grand Rounds, and have a good rest of your week. Be well.
It's been an honor and pleasure. Thanks so much for having me.